So just as a kind of reminder, these were questions that people asked, but we never had a chance to ask them on the event itself. So we offered people to record it and then share it with people so they would be able to access it. So I'll ask you the questions. I broke them down into 4 categories. One was medical, another training, medical technical questions, training, demand generation, and just a couple of general questions. So we'll just start with the technical part. You mentioned antibiotics and the prepackaged medicines in addition to analgesics. Could you expand a bit on what you put into the package?
Sure. So antibiotics for vasectomy clients is not a universally practiced thing, but there are some countries that have national guidelines which say that clients undergoing vasectomies should be prescribed some basic prophylactic antibiotics. And in such countries, we include that government required dosage of the government recommended antibiotic type into that pack. That's all that means. We don't have a universal antibiotic regimen that we use for vasectomy patients.
All right. Second, do you find that there are less incidents of post-vasectomy pain syndrome in developing countries? And if so, do you think in part it might be because most poor people are not comfortable complaining to institutions that might traditionally be unresponsive?
The first part of the question, yes, we have never really had a complaint of post-vasectomy pain syndrome. I do not think that a reluctance to complain could be the only reason. It might be part of it. I honestly can't really say, I can only assume, but I know I'm going to raise eyebrows and probably cause some backlash by saying this, but not everybody is convinced that the post-vasectomy pain syndrome is a real thing. So our providers don't seem to come across this at all. And at 15,000, 20,000 vasectomies a year, we never hear of it.
Interesting. Training. Do you have guidelines to train doctors, and what criteria do you use to determine when a doctor in training is actually ready to perform vasectomies?
Yeah, that's a great question. So we have a set of things that we use for this. So first we have the vasectomy guideline, which I sort of showed during the session. Then we have a vasectomy training package, which is based on the guideline, but specifically designed for training. And then we have what we call a vasectomy competency assessment checklist, which is a tool to assess somebody's level of skill in providing a vasectomy according to the guideline. So how we do this is in different countries, different cadres of providers are allowed to perform vasectomies. In many countries, any doctor can be trained to provide vasectomies, and in some countries, cadres lower than doctors can be trained to provide vasectomies as well, like cadres like physician assistants or medical assistants, things like that. So which cadres are allowed to apply?
What's the word you use? Cadres?
Physician, yeah, cadres like doctors, nurses, midwives.
Oh, categories. Okay.
Yeah.
Yeah.
So any person in a given country, any person who has the basic qualification required by that country's law to perform vasectomy services can raise their hand and volunteer to be trained. So what we do is first, depending on the training capacity, we would ask their line managers if this person would be suitable. If so, if there's a demand for vasectomy providers, we'll organize a training. So the training would be carried out by an endorsed vasectomy clinical trainer. Now, such a training would usually be about 7 to 14 days, depending. About 40% of it would be theoretical and about 60% would be practical. And then at the end of the training, each trainee would be assessed using the vasectomy competency assessment tool. And then the tool categorizes people into 3 levels depending on what level of competency they show. And only people who reach a level 1 competency are given a completion certificate and then allowed to perform vasectomies. Anybody who reaches level 2 or 3 would basically fail the training. That's how we do it.
Is there any minimum number? Like, do you choose a number that they have to have done to be able to even take the test?
Yeah. So vasectomy training has minimum numbers of vasectomies that they should observe, that they should do, like they should assist in, and that they should do by themselves before they can be eligible for assessing.
And how does that work, like in countries with really low numbers, you know, like when you don't have a, you know, that challenge of you're trying to build capacity,
so
but you know.
Any country that wants to put a vasectomy training together, or any clinical training for that matter, tubal ligations, manual vacuum aspirations, have to organize the site as well as the necessary client numbers based on the number of people to be trained during that training. So, for example, if a vasectomy provider has to do 3 vasectomies by himself before being eligible for assessing, and if you are training 5 people, they would have to have a minimum number, about 20 clients ready for that training period.
What do you find, like what is the reason that in some countries there's more acceptance than others, like vasectomy that gets more popular than others? Is that cultural? Is a reflection of a country director, an individual provider? What have you learned?
It's a combination of things from what we have seen. I think 3 things play significant roles. The first is government support. Countries where the governments have run large scale government vasectomy programs in the past, or are currently running government sponsored vasectomy service programs, in those countries vasectomies tend to be more acceptable and more known. Leadership of the programs, yes, is a main role as well. Countries where country directors, or regions where regional directors push vasectomy services as a key service to be provided, do perform more vasectomy services. And finally, there are some countries where there are very ingrained misconceptions and myths, and these are not limited to ordinary people. These are also ingrained within the medical communities. So I think those are the 3 main things that play a big role.
Right. Do you find that how closely does MSI work with ministries of health in each given country in terms of
that changes a lot from country to country, Jonathan. So in some countries we directly subcontract to the government. Examples are UK, South Africa, India, where we perform tubal ligations, vasectomy services as part of the Indian government's permanent contraceptive program, and we get paid by the government. And in some other countries we provide services, but the services are provided by our clinicians, but the service provision happens in government health facilities. And in other countries we have a combination of either we just train government people, or we allow government providers to come and provide services with our teams in some locations and things like that.
Over the years, you know, we know that there's a lot of resources to help educate women about long-lasting methods and family planning in general, and there's less so for men. Have you guys yourself developed your own materials to create demand or educate the public about vasectomy, or do you leave that to each country? How does that work?
We leave demand generation to each country. Countries who need support can communicate with MSI's central marketing team in London, and they would help them work with the selected company to develop contextually appropriate campaigns. And I've seen quite good vasectomy campaigns in Nigeria, and some in Papua New Guinea, and some in a few in India.
Yeah. Do you find that do you usually group them together? Does MSI like have like a vasectomy clinic where it's all like done on a, you know, one day a month or once, or do you tend to just let the clients decide?
That depends again, both on countries, but also what we call the service delivery channels. So for example, in Bangladesh or countries where there's a bigger demand, in our clinics, MSI centers, in some of those there are vasectomy providers, so that we don't have to organize things. Anybody can sort of walk in and get a vasectomy, but those are a minority. Usually we have outreach like mobile surgical teams, and then those teams visit different locations every day, and then some of those teams have vasectomy providers, and then prior to the team arriving in a given location, there would be demand generation teams that spread the message so that men who want a vasectomy would show up at that location on that day.
Final question was, but maybe you answer because you don't have a lot of complaints about the service, but are doctors or MSI legally, you know, have there been any problems with lawsuits?
A few. We had 2 or 3 lawsuits that come to mind over the last 6 years on vasectomy failures. But the thing is, you know, there is a small failure rate. While it's one of the most effective, efficient methods, there's always the potential for a failure. So I don't think any of the cases went to court. I don't know how they were resolved because I'm not involved because these are in-country legal matters. So I don't know exactly how they ended up. But I do remember 2 or 3 vasectomy failures being raised by clients. In terms of incidents or complications, we've seen a few hematomas. I think one or two, like what do you call it, a spermatocele or something. Other than that, nothing serious. Maybe 1 or 2 minor infections. Other than that, nothing comes to mind. But those things did not come to us as a risk or a potential lawsuit.
All right. Well, listen, thank you so much, Dhammika. I really appreciate your time. Those were the questions, and that was pretty simple. But
No, absolutely. I'm happy to help. I understand sometimes my level of detail might not be enough for some of the members, but if there are specific questions, do ask them to throw them back at me, and I'll get my clinicians to give more detailed answers.
Excellent. All right. Well, have a great day, and thanks so much. Stay safe. All right.
Absolutely. You too, Jonathan.
Take care.
Take care.